A brief overview about the tunnel enlargement. Our patient was a teacher, 35-year-old teacher. We gave a history of injury while he was getting down a motorbike, while he was parking it. And the limp index was 3 out of 4. And we performed ACL reconstruction after 3 months of the injury. The MRI was done after 2 months of injury. This is the MRI. There is non-visualization of the ligament, suggesting the ACL tear. And there is some amount of contusion in the tibia, shown by the red marker here. And in this coronal section as well, this is T2 weighted signal. And there is contusion in the posterior aspect and also on the lateral aspect of the tibia. But there is no contusion in the femur. This was done after about 2 months of his injury. Then this patient had been presenting to us. And we used hamstring autograft with quadrivalent autograft until we achieved the 8 millimeter diameter. And then we drilled with a reamer of 9 millimeter in both the femur and tibia. We used suspensory fixation for femur, while the interference screw for tibia. And the rehabilitation was started on the second post-operative day. And there was no untoward event during the hospital stay. And the patient has been presented to us with a complaint of pain on his left knee on and off over the last 1 year period. But there was no giving way and there was no history of trauma. And we examined the patient. The patient had hard endpoint, but there was increased anterior translation as compared to another knee. And there was no ligament laxity in that patient. And Ben Venuti in his study had shown that Lachman test is a good assessment tool, good qualitative assessment tool for assessing the degree of anterior translation in contrast to but this is a poor test for quantitative assessment of the degree of anterior translation as compared to the devices like arthrometer or rollimeter and other manometers. The pivot shift test was negative. So we went for another MRI. This is 1 year after ACL reconstruction. You can see here, this is the status of the ACL. This is the reconstructed ACL, and this is Howell stage 3 of the reconstructed ACL, meaning this is one of the stages of ligamentization. This hyperintense signal following the ACL reconstruction does not mean that it's been torn. This just means that this is one of the stages of ligamentization, and that stage is synovial infiltration or granulation tissue inside the reconstructed ACL graft. So we should be very careful in interpreting the reconstructed ACL. We see the hyperintense signal chains. As long as the fibers are intact, as long as the fiber are continuous, the graft is still intact. But then we drew ACL Bruman line angle. This is a very handy parameter to say that the ligaments are intact or not. But in one film, the apex is towards the femur, while in another film, the apex is towards the tibia. But still, the graft is intact. So if you follow this ligamentization process in the subsequent periods, the signal chains may disappear. So this may be normal in case of up to 9 months, according to one study. So this doesn't necessarily imply there's something wrong with the ACL graft. But let us focus towards our topic, that's the enlargement of the tunnel. And we measured the tibial tunnel. Tibial tunnel was 15 millimeters in the axial section as well as on the sagittal section. Actually, we used this scale mentioned in the MRI itself. We didn't use the software to measure the diameter, so we didn't get this in decimal. We got in whole numbers, whole figures. And the femoral tunnel is 12 millimeters in diameter. So the tibial tunnel enlarged by a greater degree as compared to the femoral tunnel. This is again what the studies show, mainly because of the more degree of tibial contusion as compared to the femoral contusion. There may be more enlargement of the tibial tunnel rather than the femoral tunnel. So our impression is graft laxity because the Lachman test was positive. I mean, Lachman test, there is increased anterior translation, though the endpoint was hard as compared to the normal knee. And this secondary to bone tunnel enlargement. This is actually the CT scan, but not of this patient, but this was taken from another patient. And a study says that CT scan is more sensitive to diagnose the tibial tunnel status as compared to the MRI. But again, some other studies say that MRI and CT scan are equally sensitive. And MRI, in addition, gives us the information about the status of the ligament. So MRI may be better, but there are conflicting studies. And another important aspect, another important fact proved by Silva et al. In his study says that bone tunnel enlargement does not necessarily lead to graft laxity in all the cases, but in some cases, it may lead to laxity. So we should be very careful in interpreting whether bone tunnel enlargement is really the cause of graft laxity. So let us briefly talk about the causes of tunnel enlargement. There are biological causes and then mechanical causes. There is one effect. This is the graft inside the tunnel, and this is the suspensory fixation, while this is the interference fixation. And there is some amount of free graft still inside the tunnel. The screw is pushed way towards the lateral. And in case of the suspensory fixation, there is a good deal of free graft inside the tunnel. And with every movement of the knee, the graft moves longitudinally. It lengthens and then shortens, both in cases of suspensory fixation and interference fixation, thereby leading to some lengthening of the graft and also wear and tear of the tunnel. This is called bungee cord effect, as if the cord of the bungee jump is lengthens and shortens. This is called bungee cord effect, and this is one of the important causes of tunnel enlargement. And there's another effect called the windshield wiper effect. This is the graft doesn't move only in the longitudinal axis, but also along the transverse axis, thereby causing the dilatation of the tunnel, enlargement of the tunnel. This resembles the windshield of a vehicle. So this is called windshield wiper effect. These effects cannot be negated when we've used the interference, we've used the suspensory fixation. But in case of the interference screw fixation, if we are able to minimize this free graft inside the tunnel by placing the screw right at the aperture, but not pushing way towards the lateral cortex as shown in this figure. So if you are able to put the screw right at the aperture, these effects may be minimized, thereby minimizing the bone tunnel enlargement. Another effect, some studies say that early and aggressive rehab may lead to bone tunnel enlargement. And biological causes are bone necrosis while drilling. So again, some authors suggest serial dilatation of the tunnel to minimize the bone necrosis, thereby minimizing the graft slippage during the physiotherapy and during movement. And cytokines, the inflammatory mediators that are present inside the synovial fluid, these are not within our control. And infection is another cause of bone tunnel dilatation, one of the dreaded complications, infection. The polylactic acid, that is the component of the screw itself. This causes a drop in the pH value of the fluid, thereby causing the dilatation. So these days, the screws with hydroxyapatite coat has been introduced to minimize the drop in pH, thereby minimizing the bone tunnel enlargement. Contusion, again, the contusion that's in the acute phase of the injury, if there is extensive contusion, then there drilling in the contused bone, which is already inflamed. This can lead to further inflammation, leading to further enlargement and sometimes infection. So what is the significance of the tunnel enlargement? Is it so grave? Is it so harmful to the patient? The incidence is 74% of the tunnel enlargement. if the incidence is so high, if this was so dangerous, if it was so harmful, then all our patients would land up in a whole lot of complications. But this is not, the tunnel enlargement does not necessarily lead to complications, does not necessarily lead to graft laxity. The question arises, the problem arises only when we are going to revise the surgery because of the enlargement or because of other causes. This is going to create some difficulty. And if it has caused laxity, then the outcome scores are poor, especially because in unstable knee, in the joint, in the knee with joint laxity, this is going to be unstable and this is going to cause further injury to the cartilage and also with the meniscus. So the outcome score may be poor. And while interpreting the laxity clinically and also by MRI, there's one more fact that's very important to understand. That's the process of ligamentization. The necrosis and remodeling occurs in the first 9 months. This is the weak period. And during this period, the graft may appear lax, but that's well and good. That's not harmful. That's the normal phenomenon. But if we see the laxity well beyond the 9 months, well beyond 1 year, then there is something wrong. This laxity may disappear. This graft laxity may disappear after 9 months or after 1 year, once the graft has entered into the stage of maturation. So,
can you summarize? Already exceed your time.
Yes, sir. Thank you, sir. So I've almost come to the end of this topic. All I want to share is that bone tunnel enlargement may not be as grave as we think it is. So we should carefully interpret this incident. Thank you very much.
Thank you, Sushil sir, for your wonderful presentation. If there are any questions by the guests, they can keep up in with the chat box. Now we are going to start immediately with other presentation by Dr. Ravi Bhandari from Shree Birendra Hospital.
So am I audible, sir? Am I audible?
Yes, you are. You are.
Good morning.
Yes, Ravi, you are audible.
Good morning, seniors and colleagues. I am Dr. Ravi Bhandari. I am Ravi Bhandari from Shree Birendra Hospital. And my topic of presentation is stress fracture in military recruits. So, first of all, the stress fracture occur in normal bone. That goes through repetitive small stresses. That is also called microtrauma. And this stress fracture is also known as mass fracture or fatigue fracture. And typically, this type of stress fracture are common in military personnel, athletes, and dancers who do repetitive exercises. And this stress fracture was first coined by Prussian military physician Betop in 1855. The loading initiates bone remodeling, that is the combination of bone resorption and bone formation in accordance with the is continued, then is if it is prolonged, then the bone resorption occurs faster than the new bone regeneration that leads to the stress fracture. And stress fracture passes through different stages like the crack initiation, followed by propagation, and then to the complete fracture. So our first case, the 89 years male recruit under training for 3 months, presented with pain in his left leg for last 1 week, and there was no significant history of trauma. On local examination of his left leg, mild swelling was present and point tenderness was present. So we sent a plain X-ray. The plain X-ray was normal, and so the patient was asked for rest and follow-up in 2 weeks. When the patient was follow-up after 2 weeks, then we sent the X-ray that showed the focal periostal cortical new bone formation that suggests stress fracture of his left leg, and the patient was managed conservatively on long leg cast. So to diagnose the stress fracture, we have some clinical presentations and imaging. So usually we have to ask whether the patient is under training or not. Pain is insidious in onset, and the sequence of presentation of pain is initially the pain is only after the activity, followed by the pain only during the activity, and at last we'll have rest pain, and there is no trauma or any significant injury history. And usually on local examination of the stress fracture, the palpable swelling may be present, point tenderness are usually present, and hop test is positive. This hop test means the patient is asked to jump on his leg, so on the affected leg, that causes pain on the leg. So initially, the plain X-ray are usually negative in early 2/3 of the course, and that becomes significant or that becomes positive when after 2 to 3 weeks later, that shows some localized periostal elevations as shown in the picture. So this is the plain X-ray pelvis of a female recruit, 19-year female recruit who presented to our center, and the X-ray shows right inferior pubic rami stress fracture. This is another X-ray that shows the femoral neck, complete femoral neck stress fracture of left femoral neck stress fracture, and the third picture shows the stress fracture of the middle tibial plateau. That is more clear. That is more clear on MRI. So these are the that we usually encounter in our OPD during our day-to-day activities. So these stress fractures are very common in military population. So, but this is not always the case. There are some wrong diagnosis of stress fracture that has happened. So among these, the first picture, it was diagnosed as a chronic osteomyelitis, and the second picture, the patient was suspected as some malignant bony tumor and was sent to our center for further evaluation and treatment. So there is always the chance of delayed diagnosis, wrong diagnosis, or the misdiagnosis in case of stress fracture, because there is always the chance that it is said that there is always the chance of misdiagnosing this stress fracture with the osteosarcoma because of its clinical, radiological, and the histological characteristics of this type of this fracture. Because if we do histology, then the healing callus may show, or it may be consistent with the osteosarcoma. So when the initial X-ray is doubtful or it is negative, and but the patient has strong clinical suspicion, then we go for bone scan. Usually it is 100% sensitive but lower in specificity than MRI. And second one is the MRI, which is more sensitive and specific, from which we can see the soft tissue status and the bone edema, and it is considered as the gold standard. And last, the CT scan that delineates bone well and helps to differentiate between complete and incomplete. And CT scan is usually done when MRI is contraindicated. So in our center, most of the time we do MRI, and few of the cases we go for CT scan, and we don't have any experience of bone scan. So next case, this was a patient who presented with right hip pain and limping on his right limb, and the X-ray was sent. That was doubtful, and so we sent the MRI that showed the complete stress fracture of right neck with bony edema, and this patient was treated operatively. The another case he complained, he came with the pain on his right hip and limping, but he didn't, but when the X-ray was done, then we see, and when the X-ray and the MRI was done, then it showed the bilateral femoral neck stress fracture at different grade of presentation, and this patient was managed operatively. So there are various classification and grading system for stress fracture, and the most useful one is the is according to the location, in which it is divided into high risk stress fracture and the low risk stress fracture. Low risk, the high risk stress fracture are those that have one of the following characteristics, at least one of the following characteristics, that are delayed union, non-union, risk of refracture, or progress to complete fracture. The few of the anatomical sites of this high risk stress fracture are femoral neck, intervertebral cortex, patella, middle malleus, talon neck, fifth of base of feet, metatarsals. So for the management, the algorithm, usually when the stress fracture, according to the anatomical location, if it is high risk and the X-ray shows complete fracture, then we do operative treatment. And if it is not complete, then we do conservative treatment in long leg cast. And in case of low risk, we first of all, it depends upon the symptoms. If the patient if there is no limitation, then we do activity modification. And if it doesn't help, then we go for cast or slab immobilization. So now, finally, the take-home message: the activity-related pain in military, we should consider stress fracture. Early diagnosis is easy treatment because it prevents from propagating it to the complete fracture. And initially, plain X-ray is usually negative. MRI can be done in case of doubtful and high-risk fracture, and it may be sometimes mistaken for osteosarcoma. Thank you.
Thank you, Dr. Ravi, for your presentation. If there are any questions, you may please put in the chat box. So I would like to welcome now Dr. Sachin Kumar Yadav. He is from CMS Bharatpur, Chitwan. His topic is arthroscopic treatment for ankle impingement and synovitis. Thank you very much. Dr. Sachin. Dr. Sachin, are you there? Hello, Dr. Sachin, are you there?
He doesn't seem to be, isn't it? Hmm?
अर्को प्रेजेन्टेसन गराउँदै गरे हुन्छ नि त.
Okay, sir. Thank you, sir.
You can do another one. By the time he comes, then you can start.
He is there, but he's not been able to share his slides. Yeah.
Okay, sure.
I think we'll start the next presentation, and later on Sachin will present his topic.
That will be better. That will be better.
Okay, thank you, sir. Sir, the next presentation is by myself. I'm Dr. Mohit Thabamagar from Shree Birendra Hospital, Chhaoni, and my topic is chronic exertional compartment syndrome of leg. Good morning, sir. My topic is chronic exertional compartment syndrome. And starting with, as we know, in the military career, one has to walk around, run around with the baggage, equipments, and in the morning, afternoon, or in the evening, or the land, or in the hills. So, and it's all done under the timing. One has to rush to be in time. So this is the general introduction of our daily military activity. So moving on to our case, our case is 41 years old serving soldier who presented with complaint of pain and tightness and cramp in both the legs with difficulty in walking and bearing weight. He similarly had previous history of pain in both legs following exercise previously as well. So this event occurred after he ran 42 kilometers with 10 kgs pack, and there was no history of trauma. And initially, patient was managed by at nearby center with analgesics and cryotherapy. However, with unbearable pain, the patient was lifted to our center after 2 days. So on examination, after he approached here, there was a firm diffuse swelling over the anterior aspect of the leg in bilateral, and tenderness over the anterior lateral aspect attenuated by dorsiflexion of the foot. Whereas there was a passive stress test was positive and there was no local rising temperature. And the range of motion at the knee joint was full, but he was unable to dorsiflex both the foot. And however, the distal neurovascular was intact. So after we can see the clinical picture of the patient with bilateral legs, and we can see his pain swelling on the anterolateral aspect of the right leg and swelling on the anterolateral aspect of the left leg. So after that, we investigated, routine blood investigation was done, and with X-ray was done bilateral to rule out any stress fracture or shin splints or shin splints. And ultrasound Doppler was done in emergency to rule out any DVT or any arterial cause. So initially we put the provisional diagnosis as chronic exertional compartment syndrome. So moving on to procedure, we gave for chronic exertional compartment syndrome, fasciotomy was done with a single anterolateral incision for the decompression of the anterolateral compartment, sequentially left first, then the right, and single mini medial incision given on the posterior medial border of the tibia for the left leg. But as we opened the compartment, what we saw was dreadful. And approach, again, we can see the compartments. And first approach was given anterior lateral incision, and with the anterior and to see the anterior and the lateral compartment of the leg. So on findings, what we found was dreadful, and we can see there was myonecrosis of the anterior compartment of the right leg, and myonecrosis of the anterior compartment and the anterior lateral compartment of the left leg. So as I said, there was no, but however, there was no involvement of posterior compartment in both the legs. So debridement was done with the removal of all the necrotic tissues, and initially which was closed with shoeless sutures. So moving on to, and after the admission, the patient systemically, he was also unstable for certain days, as there was fever from the second day of admission, and there was swelling of the whole body, and there was initially decrease in urine output. So these all symptoms and these all features gave us some idea about the rhabdomyolysis, in which investigation he had anemia, which was countered by blood infusion and increase in creatinine kinase, which was managed with medical physicians, and hypoalbuminemia, which was also dealt with albumin infusion and other protein diet. However, throughout his admission, the renal function. So what we did was debridement and debridement. Subsequently, due to myonecrosis and repeated debridement was done by us. And again, VAC dressing after the debridement, after we thought that there was a viable tissue, and after we thought that there was no infection on the compartment of the legs, then we started with the VAC dressing. It was a modified VAC dressing with the help of our reconstruction surgeon. and which was changed 3 times bilateral. Sorry, sir, for the interruption. This modified bag dressing was done using our normal suction tubes and tetra cloths and use of a incisional drape. So after the bag dressing, we after dressing around 25 to 25th day, there was a split skin grafting was done on the right, and on the left side, the secondary closure was done with SSG grafting. So rehabilitation and complications. Patient was kept in foot drop brace throughout the admission with passive range of motion, which was started immediately after the surgeries, and mobilization started with auxiliary crosses and then with the walking stick. And due to myonacrosis and necessary debridement, the patient acquired bilateral foot drop. And now we have planned for posterior tibial transfer to the dorsum of the foot in future with the reconstruction, with the help of reconstruction surgeon. So main is note we have to take home message is that in this was a rare case which we thought was a chronic exertional compartment syndrome, but however, though it was automatic, it developed into a automatic acute compartment syndrome in the setting of the exertional mechanism. So as we think about chronic exertional compartment syndrome, transient increase in pressure of the muscles in compartment during exercise, which leads to an ischemia and increase in intramuscular volume up to by 20%. So the leg accounts for more than 95% of all the cases, and CECS is bilateral in 75 to 90%, in which anterior compartment is affected most, 40 to 60%, followed by lateral compartment, deep posterior compartment, and the superficial posterior compartment. So on conclusion, this case, which we thought was a chronic exertional compartment syndrome, brings to attention that even in automatic condition, due to highly repetitive and prolonged activities requiring sustained angle dorsiflexion, can serve as mechanism for development of acute compartment syndrome. So delayed diagnosis results in permanent disability and need for multiple surgeries. So with this, I would like to conclude my presentation. Thank you, sir. So is Sachin, Dr. Sachin ready with his presentation, sir?
Mohit, I think Sachin is ready now.
He's ready, sir.
Okay, sir.
Mohit, I think Sachin has problems, so I think we can start another presentation.
Okay, thank you, sir. Now, I would like to request Dr. Vivek Basupala, sir. He is from BNB Hospital, Guarco, and his topic of presentation is tracheoplasty for patellar instability, secondary to trochlear dysplasia, our modification. Thank you, sir. You may start with the presentation, sir.
Thank you, Dr. Mohit. I'm going to share my screen. Am I audible and my screen is visible, Dr. Mohit?
Yes, sir. Yes, sir. You are, sir.
Okay. Respected seniors and colleagues, I'm Dr. Vivek Basukala. I work in AKB Center for Arthroscopy, Sports Injuries and Regenerative Medicine. Today, my topic of discussion is trochleoplasty for trochlear dysplasia or modification. This trochleoplasty is a very uncommon procedure, not only in our country, almost it is not so commonly done in our neighboring countries and also not so commonly done in many parts of the world because of fear of many complications. So we describe in this presentation about our modification of this complicated procedure. So as we all know, the patella is the largest sesamoid bone of the human body. This patella articulates with the trochlea at about 0 to 20 degree of flexion. Patella moves from lateral to medial side, and at about 20 degree of flexion, this median ridge of patella gets stuck into the trochlea of the sulcus of the trochlea, and from then onwards, the trochleal sulcus guides the movement of the patella, which is called the patellar tracking. And this is the movement of the patella while a patella tracks. And when this patella dislocates from its trochlear position, this is called patellar dislocation. Various causes of patellar dislocation may be extrinsic, like rotational deformities of the lower limb, the angular deformities, the pes planus deformities, and intrinsic causes may be the high riding patella, the patella alta, the trochlear dysplasia, and sometimes this may be because of lax medial structures like MPFL and tight lateral structures like cicatrized lateral bassus lateralis and all. So let us hear from the master himself. Henry Digio in 1994 published this very landmark paper in which he described that in any form of objective patellofemoral instability, he found almost about 96% of them had trochlear dysplasia of some kind. So they may not be so severe to warrant for surgery, but trochlear dysplasia was present in almost about 96%, and this was present only in 3 to 6% of control. So patellar dysplasia is not so uncommon condition. Maybe they may be not so severe. So let us talk to evaluate the patellar dysplasia. Various techniques has been described by Dejer himself, and he describes various techniques on X-ray plane radiography. The lateral view, the ideal lateral radiograph is the overlap of medial and lateral condyles. The Blumenscheidt lines will be parallel with the floor of trochlea. This is anterior line is the floor of trochlea, and this corresponds to various landmarks in axial view. So as shown in this picture. So this is Desor classification given in 1998. Type A is shallow trochlea in which there is crossover sign where the floor of trochlea crosses the condyle. Type B is the severe one, relatively severe one, where there is crossing sign along with the supratrochlear spur because of anterior prominence of the condyles than the trochlear floor. Then type C, there is crossing sign along with the double contour sign because here the medial condyle is hypoplastic and the lateral condyle will be more prominent, and the double contour will be seen because of the overlap of the medial condyle. And there will, in type D, there will be all the signs present: the crossing sign, supratrochlear spur, and double contour. And the particular cliff sign is present in the axial X-ray, which is a sign of severity of this particular condition. So the patellar height is very essential to be measured in every case of patellofemoral instability, also in patellar dysplasia, trochlear dysplasia. Caton Decime index and Insel Salvati index are most common one. So this trochlear dysplasia and instability thereafter can be compared with this bowling game, and the ball can be compared with the patella, and the floor can be compared with the trochlear surface. If the floor is elevated at the middle, what happens is whenever we bowl this ball, it won't go in our desired direction. It will fall on either side. So this is the corollary in which we can the trochlear dysplasia can be explained, because there is no good surface where patella will be tracked and patella will be pushed into the lateral compartment because of high riding lateral femoral condyle. So MRI investigations, the fasces is asymmetry can be measured, and the asymmetrical, the angulation of the medial patellar medial trochlear facet, if it is less than 11 degree, this is very, very severe form of the trochlear dysplasia. CT scan depicts the bony architecture even more detail, and the TTTG distance is very important in any form of instability, even in trochlear dysplasia, and more than 15 to 20 mm is sign of some procedures with distal realignment procedure. So many types of trochleoplasty has been explained. First one is LB, in which the medial femoral condyle is elevated. Second one is sulcus deepening trochleoplasty described by Dejour and Massey. And another is Gottelier recession trochleoplasty. Nowadays, the famous one is Veritier thin flap sulcus deepening trochleoplasty, which is the modification of sulcus deepening procedure of Dejour. And this is, we modified this particular technique. So this is the animation in which we have shown how we have done this procedure. So we make the flap at the osteochondral flap with the help of this osteotome. We at the osteochondral junction, we tap with the osteotome and we burr the inferior surface of this osteochondral flap, so that the thin osteochondral flap will be prepared. The new sulcus that we have planned will be created with the help of osteotome, and then we press this new osteochondral flap, drill and put one with knotless anchor, then tie those threads along the femoral shaft. So this is how the trochleoplasty is done. I present our case. This is 26-year female. She had history of bilateral patellar instability. She was operated multiple times in last 15 years. No surgery had benefited her. This is her examination finding, clinical examination. You can see the mal-tracking patella bilaterally, both in right and left sided. And this was her X-ray. The medial femoral condyle and lateral femoral both were not well developed. This is the lateral X-ray in which anterior bump of the lateral femoral condyle can be seen. And this was the CT scan in which trochlear dysplasia and increased TTTG distance is seen. MRI showed lateral inclination of the patella along with mal-developed trochlea. So this was after we operated on her in left side, and this was about 1.5 years after the trochleoplasty in left side. So we can see the left side has healed. The tracking of left side is okay, but there is still mal tracking in the right side. So she came because she was very happy with the first surgery, and we planned the second trochleoplasty on the other side. This is the short video on what we did. So we opened from lateral parapatellar incision. This is the trochlea. We planned the new trochlear position, and then we, just as in animation, we started elevating the osteochondral flap. We made sure that the weight-bearing tibiofemoral articulation is not elevated, and we made sure that the flap is not broken in between, and there is almost about 5 millimeter of bone underneath the articular surface. So gradually this process must be very, very meticulous, because you may inadvertently injure the cartilage, and it may be more harmful than doing good to the patient. So the bump is excised with the help of saw, and now the new sulcus position is marked. Then the two tunnels are created, and the threads are, the suckling sutures are being secured. Now what we do is we insert a knotless anchor with preloaded 3 vicryl 20 vicryl sutures, and this is the knotless anchor is being deployed. Now the next step is we shuttle all those sutures through previously prepared tunnel over the metaphysis, proximal metaphysis of that particular condyle. And this is the final picture, how it looks. This is the final picture. The new sulcus has been created. This is the final picture. Sorry. So new sulcus has been created. This is the final picture. And we also did the lateral lengthening. This is the final picture. And this was the previous condition, and that was after trochleoplasty. And almost always trochleoplasty must be added with the MPFL procedure, because medial structure is always lax, and this is stable, well-tracked patella after the reconstruction. So take home message is trochleoplasty is not a procedure for all form of trochlear dysplasia. Maybe type B and type D dysautonomia are candidates for trochleoplasty. Preoperative workup is very, very key to success. Optimal osteochondral flap prevents complications, and add-on MPFL reconstruction is always required. The trochleoplasty is the technique in which the anatomy is changed from the mal positioned trochlea or mal shaped trochlea to the normal shaped trochlea, and by doing so we are changing the axis of the trochlea. That's why even the TTTZ may be corrected, and sometimes it may be the only procedure that may be required. Even TTTZ is increased preoperatively. Thank you so much for kind attention.
Thank you, sir, for your wonderful presentation, sir. Now, if Dr. Sachin Yadav, sir, is ready, then we can start with him, or shall we go forward?
Sir, can you hear me? I'm Dr. Sachin.
Okay, welcome, Dr. Sachin. So you may start with your presentation. Thank you.
Yes, sir. Sorry for disturbance, and I'm speaking from other and sharing my screen on computer right now. So sorry for disturbance. And today I'm going to present about the arthroscopic treatment for ankle impingement. I'm Dr. Sachin Kumar Yadav, lecturer in Department of Orthopedic in College of Medical Science. So before going to present my case, I'd like to introduce ankle impingement, which is first described in 1949 by McMurray, described as a footballer ankle. Ankle impingement referred to abnormal entrapment or contact between two structures resulting in pain, restricted in motion, and pain, also limiting the functions of the ankle joint. So soft tissue and osseous discontinuity found in ankle impingement. That includes osteophytes and sometimes torn fiber band. So here we have the most vulnerable ligament at the anterior talofibular ligament, which is commonly get torn with the ankle sprain, and that get trapped into the joint. Just because we have less time, so I try to show you as soon as possible to the my case. And etiology is varies. There is a multifactorial direct microtrauma to the talus and tibia is one cause. Repetitive dorsiflexion, traction injury, inversion plantar flexion, or ATFL injury. These are the common cause for synovitis and impingement syndrome. There will be also degenerative changes cause impingement and osteochondral lesions. Most of the time we can see with the synovitis, and post-traumatic lesion also can be found with the articular margin. And osteophyte most commonly we also see on patient who are physically active, very active, or those are on sports, especially football players and jumpers. Those are on those get the osteophyte and very commonly. So symptoms usually we found is a sign of ligament instability, abnormal alignment, joint effusion, and soft tissue edema around the ankle. The localized tenderness and limiting dorsiflexion, plantar flexion, also restriction on the movement might be found. Most of the time, this is a finding on examination. There would be palpable bony lump on distal and superior talus. This new study suggests that clinical examination has been reported 95% sensitivity and 75% specificity in detecting impingement syndrome. So this is clinical examination alone is very sensitive to efficient to diagnose the impingement syndrome and pathology of the ankle joint. But to help to enhance the diagnosis, we also go for the imaging. So before going, this is a patient I see a few days ago, and she is 17 years old. She had lateral gutter swelling at the lateral region, and also she having not prominent medial malleolus at the left ankle. That is because of the followed with the trauma, and this is already 3 months old. So she having chronic pain at the ankle joint, and she came for the definite treatment. So before starting going through the making diagnosis or going for treatment, we start with the X-ray, and most of the time X-ray comes normal. If you see the MRI is less efficient than the clinical examination for the ankle joint comparatively to the knee joint or shoulder joint. So we should not rely on MRI finding alone, but the clinical examination had good diagnostic power, so we can use the clinical examination and MRI together. So on finding MRI, we can see some spur and effusion at the anterior talar joint, subtalar joint. So anterior impingement is also common. So you can see effusion and scar tissue at the anterior lateral or anterior medial. Also the posterior are also common. So in second picture, we can see here, this is a scar tissue or impingement, you can call it, that is lying between the anterior lateral braces. So that can causing persistent pain and swelling. So in this MRI, and this is a arthroscopic finding from other study, I have took this picture just to show you. So even a small amount of tissue that can cause huge impingement and pain to the discomfort to the ankle joint. So we should not neglect for the very proper finding or on MRI, or when we go to the joint, we just see a small scar tissue that also can be debrided, and that will relieve a lot of pain, and patient will feel comfortable after surgery. So indication for surgery is not, there is no restrict and proper indication, but in many studies they say like if there is failure of improvement on symptoms with conservative management, including intra-articular steroid injection, patient activities level, patient who are a sports person, young person, or they are demanding, then we can go for arthroscopic surgery. Also in ankle instability, we can, this is a necessity to do the surgery, even it's open or arthroscopic. And diagnostic purpose is always open to make a diagnosis and for the treatment. So at the time, if we fail with the conservative management, we can also go for the arthroscopic diagnostic purpose. So it depends, you do the open or arthroscopic surgery. Definitely the arthroscopic surgery have more advantage than the open surgery. And we can also use the 4 mm 30 angle arthroscope despite of 2.7 scope. If available of 2.7, then that is much better to assess the tibiotalar joint. But with the 4 mm, we cannot enter through the tibiotalar joint. So we cannot access the whole ankle joint. So here we have another. Now I would like to talk about the first case. 60 years old lady with right ankle chronic pain. She had a history of 12 years ago, right ankle sprain, which is not improved with the conservative management. On presentation, she had a swelling anterolaterally tenderness localized medially and anterolateral. She had a limitation on dorsiflexion and painful ROM. She had no stability during the clinical examination. We have some. We have finding of. So we can see on axial view, she had effusion at the anterior lateral area and posterior area. So I just did the anterior debridement. I didn't do the posterior debridement. So I like to show, if we see the MRI, there is anterior effusion and some scar tissue around the ankle joint. You can see here, and because MRI is not just much sensitive, so we have to look very careful for the pathology, and we can also go for the direct visualization with the arthroscope. So before making any portal or going to the making incision, the normal structure of the ankle should be known very carefully, and this is safe if we do it carefully. Pre-marking is very important to for the safer surgery, and there is that how we can ignore the complications. When we go, it's like landing on mine's land, but if you do the proper pre-marking, it will prevent you to go for the prevent from the further injury or other complications. So it's not that complicated, but we can do it very careful, very easily if you mark it previously. So this is my video for the patient. I'm making anterior medial portal at just medial to the just medial to the anterior tibial tendon, and 1 centimeter lateral to the from the malleoli. So there is soft spot. You can we can see on during the marking, and main thing is at the lateral side. Sorry, at the lateral side we can see the superficial peroneal nerve, which is visible on thin patient from grossly can be seen before on the skin. If the patient is thin, we make the incision lateral portal just medial to the branch of superficial peroneal nerve that has 2 branches. One is lateral, one is medial. So we make anterior lateral portal just medial to the lateral branch. So this is the way we can mark before the surgery. And here this is the way we can do the debridement in these cases. For her scenario, when I enter from, this is a view from the anterior lateral port, and we can see the scar tissue and synovitis that covering whole visualization of the ankle joint. After taking some time, we did the debridement, and this is how it looks from the outside. This is the anterior medial portal, and sorry, I unable to take anterior lateral portal from the lateral side, but roughly we have the.
We are running out of time, so if you could summarize.
So this is the debridement. We can see the osteochondral lesion here. This is very common with the synovitis and impingement syndrome. Those who have chronic pain. Okay, so I have second case. I just want to show you the clip. Okay, so this patient had, he was in under medication for 20 years. 20 years old male. He was under ATT since last 1.5 years. He had an injury of left ankle 3 years back. He had persistent pain and swelling, also the restricted movement. So he spent a lot of money outside doing the treatment, but he didn't improve. Finally, he landed to the CMS, and I see the patient. This is an arthroscopic finding on his case. So this is a scar tissue or the torn band at the lateral gutter. So this is on visualization at the start. You can see the dome and tibial distal tibia, and this is joint. So we did the debridement for these cases, and after surgery, both patients had dramatic improvement and immediate improvement. They can walk without painful. The load bearing and swelling all subsided just after surgery, and they are very happy and comfortable on first year after surgery. So this is dome. This we can see here, and we also take care of medial and some flare of the osteochondral lesion here. So this is the final outcome after the surgery, and patient feel most of the time they are very comfortable, and many researchers say that there is 100% satisfaction if you treat the local pathologies. So there is also the high chances of having, so there is 70 to 100% satisfaction, and our outcomes is good. So I also like to encourage our colleague to do the ankle arthroscopic surgery if we found with chronic impingement or instability. But only recommended those are doing the arthroscopic in knee and shoulder. Otherwise, it's difficult most of the time, and we can avoid the complications, which is account for chances of neurovascular injury at 3%, and disc of damaging intra-articular surface is high, but it is not very severe complication we made with doing arthroscopic surgery. So I think this is a very good method to give the proper and definite treatment in a patient with ankle impingement syndrome. Thank you so much, sir.
Thank you, Dr. Sachin Yadav, for a brief presentation. Now I would like to welcome our Dr. Naresh Thapa. He's a third-year resident of NIHS. His topic is anterior fracture dislocation of hip with avulsion of ASIS and AIIS. Thank you.
Good morning, everyone. Am I audible to everyone? And is my screen visible?
Yes, you are audible and your slides are visible.
I'm Dr. Naresh Thapa, third-year resident, Nepal Army Institute of Health and Science. I would like to discuss a case of anterior hip dislocation with anterior acetabular fracture and avulsion fracture of both anterior superior iliac spine and anterior inferior iliac spine. Traumatic hip dislocation is an uncommon injury accounting for 5% of all hip dislocations. Majority of it results from high energy trauma because it is well constant bony and soft tissue anatomy. Posterior hip dislocation is commonest type of the all hip dislocations. The attitude of the affected limb in posterior dislocation is flexed, internally rotated and adducted, whereas in anterior dislocation, it is flexed, externally rotated and abducted. Let us discuss about a case of 67 years old woman from Rolpa who sustained an injury over the right hip when she slept while walking on an uneven hilly trail and fell from a height of around 5 feet. She was immediately taken to the nearby hospital where X-ray of the pelvis was performed, which shows anterior dislocation of the right hip with fracture of the anterior acetabular wall and fracture involving the anterior superior part of the right ilium. Immediate close reduction was done under the spinal anesthesia, and after reduction, clinical as well as USC guided evaluation showed that the hip was unstable in extension and stable in flexion. So they applied a long leg slab in 60 degrees of hip flexion, and then she was referred to our hospital for better management. During our clinical examination in the emergency, The attitude of right lower limb was externally rotated and abducted. Swelling was noted over the anterior aspect of the right hip. Tenderness was present above the swelling. Movement was painful. However, on close evaluation, there was some amount of external rotation, but the internal rotation of the hip was not possible. Distal neurovascular status was intact. Then X-ray of pelvis was performed, which was a large fracture of anterior wall of the acetabulum with incongruous reduction of the hip joint and fracture involving the anterior superior part of the right ilium. After stabilizing the patient, we perform a CT scan of pelvis with both hip joint. We saw that there is a incongruous reduction of the right hip with entrapment of the anterior acetabular wall fracture fragment in between the head of the femur and the acetabular socket. This is the 3D picture, which shows that the avulsion of the both anterior superior iliac spine and anterior inferior iliac spine with incarcerated fracture fragment of anterior acetabular wall within the joint. Our final diagnosis of type 1C Ipstein hip dislocation, anterior hip dislocation with avulsion fracture of anterior superior iliac spine and anterior inferior iliac spine was made, and the surgery performed was ORIF with fully threaded cortical screw, and approach was iliofemoral approach. This is a post-operative X-ray where we can see that there is a concentric reduction of the right hip with fixation of the anterior acetabular wall with 2 cortical screw, and each cortical screw for both anterior superior iliac spine and anterior inferior iliac spine. These are the X-rays which was done at 6-week follow-up. Post-operative care we provide was on-traction mobilization exercise of the hip in bed from the first post-operative day, DVT prophylaxis with stockings and low molecular weight heparin for 2 weeks. At 6 weeks, toss down non-weight bearing ambulation was started with the help of crutches, and by 12 weeks, fracture showed the sign of union and partial weight bearing was started. During her recovery, she developed a superficial surgical site infection for which debridement was done, and the wound healed after 3 weeks. Her current status is she is able to do her household activities normally and she has no fresh complaint. Anterior hip dislocation forms less than 10 to 15% of all traumatic hip dislocation. According to Ipstein, it is classified as type . According to Ipstein, the anterior dislocation is classified as superior dislocation type 1 and inferior dislocation type 2. And superior dislocation is only iliac and pubic, which may be according to the relation of femur to the acetabulum. According to the associative fracture, it is also classified as type A, where it is not associated with any fractures, and type B, which is associated with the fracture of femoral head or neck of the femur, and type C, which is associated with the fracture of the acetabulum. These are some of the literature regarding the anterior dislocation of the hip. Ipstein and Harvey, in their large series of 55 anteriorly dislocated hips, mentioned fracture of acetabulum only in 2 cases. Miloski et al. Described a fracture involving anterior and superior part of the acetabulum and the anterior inferior iliac spine along with the anterior dislocation of hip. The superior type of dislocation is very uncommon variant and representing only 5 to 20 cases or 5 out of 20 of anterior dislocation in series reported by Abe et al. Superior type of anterior dislocation is easily confused with posterior dislocation of the hip, and a feature that helps to distinguish it is the appearance of lesser trochanter, which is more prominent in the anterior superior dislocation due to axial rotation of the femur. In our case, we encountered anterior wall fracture and avulsion fracture of both ASIS and AIIS with superior anterior dislocation iliac type, which to our knowledge is not reported till now. As to conclude, As to conclude, the unique combination of anterior wall fracture with an anterior hip dislocation and avulsion fracture of both ASIS and AIIS is a rare injury. Prompt reduction should be carried out with first 6 to 12 hours in order to prevent the osteonecrosis. The indication for open fracture are failed close reduction, unstable hip after reduction, incongruous reduction after due to incarcerated fracture fragment or substitute interposition, stable and congruous reduction of the dislocation with stable internal fixation of the fracture as soon as possible will allow an early rehabilitation and help to decrease complication. Thank you all.
Thank you, Dr. Naresh. As we have lost our electricity here, so I'm continuing with Dr. Naresh's laptop. So I would like to now welcome Dr. Binay from Bhaktapur Cancer Hospital to give his presentation on technical note on rotation plasty. You may proceed, sir.
Thank you, sir. I'm gonna share my screen. Is everybody seeing me? Is this visible?
We can see your.
Thank you. So I'm Binayak Dhungal from Bhaktapur Cancer Hospital. I'll be presenting on the behalf of Team SARC on rotation plasty, some technical notes. It's itself a very difficult procedure, so we'll go slow and in the notes. So this is a happy customer. We call it patients. So this patient, one happy patient is equivalent to hours and hours of hard work that you put in this procedure. So this patient had osteosarcoma of the knee, which was resected. And tibia was turned 180 degrees, and two vein and one artery where resection and anastomosis was done. She's in the chemo without disease and happy. She didn't have the prosthesis yet. So all these technical points will go on detail as we move in the slides. So there's another happy customer. He had a malignant GCT of the knee, which was resected as a salvage procedure, and a rotation plasty was done. And he is walking and happy. Let's see our history of this procedure. I don't know how to pronounce him, but with respect, I'll pronounce him as Borgrave. And he made in 1930, in which he said that did some procedure in a tubercular knee, in which that knee was totally destroyed. So he used the leg as the knee, ankle joint as the knee joint. In 1950, Dr. Van Ness in Italy basically did was 10 cases in which he used for the congenital defect of the femur, now commonly called as proximal femoral focal defect, or PFFD. So indications are when to do it. I always tell people it's not like dal bhat, it's like biryani. You know how to cook it, but you do not cook it every day. So it's for the malignant tumors of the knee joint in which prosthetic reconstruction is not feasible. There will be a lot of causes for the prosthetic reconstruction not being feasible. It's a salvage procedure for the proximal tibia or distal femoral deficiency, from including total knees to everything. So it's a single, biological, durable, fast, every good things are there, active lifestyle, excellent results, but there are a lot of hurdles to that. We'll also go in the hurdles. It's always not to look at the good things. There are hurdles to this procedure. When not to do it, never do it if you have to resect the sciatic nerve, meaning the ankle is not going to move. Never do it when the ankle is a problem, because ankle is your new knee joint. Atherosclerosis of the vessels is a relative complication, because nowadays you do resection anastomosis. And biggest point is lack of mental stability to cope with a rotated limb. In a social cultural value like ours, we need to show the patient earlier all the videos showing that how he would look like at the end of the game. So this is to start the introduction. This is a kid with a Ewing sarcoma. So we did a resection of the knee and anastomosis. This is the, if I can show my cursor, this is the skin incisions we use, the triangles we'll talk about later, to fit on the slits on the lower cylinder. This thing is resected, the knee is rotated, and this kid was very happy until he died due to the Askins tumor. Okay, so technical note wise, we'll go on all these points one by one, hopefully slowly. So incision is always a problem. Dr. Borgav and Dr. Van Ness had a problem, we still have a problem. So basically there are two cylinders. The tibial cylinder is smaller and femoral cylinder is bigger. When you match these cylinders, there's always extra skin. So extra skin, the Borgav or Dr. Van Ness used to cut it like a rhomboid. In 70s, some people started using something called like they would cut the triangles on the both sides. Didn't work well. They used fish mouth. Didn't work well. Now in 2010, somebody published a paper in which he would measure the circumference of the leg and measure the circumference of the thigh, and you would bivalve the circumference of the leg into the thigh and make two triangles. Extra skin would be made into a triangles like this, and these triangles will go into the slits of the leg, so that the end result will be like this. Since then, nobody had complication of the incision, and we also use in few patients, and we think it is a good incision. So next part is this vessel dissection. Vessel dissection is always challenging. This kid is 6 years old with a big tumor. We try to dissect the vessels with the sheath, but sometimes it's not feasible. This kid, we could not do it. We had to take it out from the sheath. This is the artery and this is the vein. We could save only one vein. So what happened, I'll show you slowly. So this is the vessel dissection part. Now, after the vessel dissection, you do a resection. Resection is easy. You cut the bones, take it out, and you have two pieces left attached with the vessel and the nerve. Now, this has to go in place to create a limb that you wanted to create, unnatural but functional limb. This is the most important thing. After resection, it's okay. Now, another way of doing it is resection anastomosis of the vessel. This lady that I showed, the happy customer earlier, had a resection anastomosis of the 2 vein and 1 artery. This is a better procedure. We have learned now that 1 vein, 1 artery is not enough. We need 1 artery and 2 veins, because the biggest complication rate is always congestion. Congestion is killing the limb. We had 2 amputations, both were due to congestion, and we'll show them. This is the anastomosis being done by our vascular surgeon. And this is the end result. You fix the limb with some plate. There are a lot of ways. This is called docking. Docking is like a boat when it goes to the harbor. So boat is this is the boat. I can show you. This is the boat and this is the harbor. So boat goes to the harbor. So there are a lot of methods of docking in which the tibia, the femur, can go inside the tibia, or you can just cut the femur and put it inside the tibia. There's so many ways. The easiest way, you're tired after the surgery because it's been so many hours, is just to put a plate, and they work similar, splendid. So you put a plate and forget about it and do the vessel management like a loop. If you have not done resection, you put up vessels in the loop on the medial side and close the skin and hope for the best. So this is the loop of the vessel. We put on the medial side, this is the plate, and this is the incision. If you look at the incision, this is the extra piece on the thigh, which is placed in the leg so that the incision end results are better. And this is the fixation, simple fixation. They always heal. The fixation is not a problem because it's stable fixation, and there is a lot of cancerous tissue in the tibia to heal. So muscle management. In the distal femur, muscle management is not difficult because all the muscles are intact. So you just have to augment the gastrocnemius with the rectus femoris. In the proximal tibia, all the muscles are cut. So you have to reconstruct every muscle, quadriceps to Achilles tendon for plantar flexion, for hamstring to peroneals, bicep femoris to posterior anterior tibia. This is difficult to understand unless you see it and do it, because that's what you have to do. There will be some muscles on the top, some muscles at the bottom. And after you dock the tibia, and you exactly don't have to think this. The upper muscle goes to the upper one, the lower muscle goes to the lower one, side muscles go to the side one. You don't have to remember these. They're very simple.
We should, I think we should shorten, sir.
Okay. So in the post-op, we try to see the venous edema. That's the most important. Congestion. This is what the congestion looks like. It has to be less than 3 seconds, but this kid has only 1. So congestion is basically looks like this at the end of the game. So you have to do an amputation if the congestion. This is because of the 1 artery, 2 vein, 1 vein. We need to do 1 artery, 2 veins. So prosthesis has always been a problem. This kid never got a prosthesis till he died. But now we have in Hariyok in Pokhara who does prosthesis, and we have these people who go there, wait to get the prosthesis done. Our patients, we had 6 patients, 3 died, 3 living, died of the disease, and the 3, 1 is living with above knee amputation, 2 are living with, 1 with the chemo, 1 is already walking. So this is vascular management. We had 2 dissection anastomosis, and 1 artery, 1 vein did not survive. So that's a take-home message. 1 artery, 2 vein survived. So this is our result of the patient. I'll just show you how he walked. This is the prosthesis. That's his limb. He can put the prosthesis in the limb and just walk. That will be another 30 seconds to see him walk. Sorry about that. My presentation is exactly 9 minutes, 30 seconds. So He's putting his prosthesis back, and he'll put his pants on, and he will sit and show you how it extends and flex, and then he'll walk. The final is this, and then they walk. Okay, this is the guy walking, and he's happy. This is the education resources. We use the MD Anderson education resource to show the patient how his limbs looks like. And there's a Gabby, the most beautiful girl who does a lot of dancing, and she will be seen in the YouTube dancing with this prosthesis. And I'll show you one more dance to end the game in the YouTube, if I can get you there. I don't know about my internet connection, sorry about that. And when you need it, they never work. So this is the kid with a rotation plasty who is dancing. This is called some kind of dance, which I don't know. Thank you. That's what I have. If you have questions, I'm happy to answer.
Thank you, Binayak Pokhrel, sir, for your wonderful presentation.
My name is Binayak Dhungela, sorry.
Sorry. Now, I would like to welcome our head of department, Sri Birendra Hospital, Dr. Lieutenant Colonel Dr. Vishnu Babu Thapa, sir, to start with his presentation. Thank you, sir.
Thank you, Mohit. Good morning, respected seniors and colleagues. Today I've chosen this topic for IC presentation because the aging group of population is increasing, and then obviously more and more degenerative condition will be increased, and so the lumbar spondylosis is one of the common cause of the spinal stenosis. So that's why in coming days we are facing more and more the stenosis cases. So spinal stenosis is an abnormal narrowing of central canal intervertebral foramen to a point where neural elements are compromised. Though there are various radiological parameters radiological parameters, but mainly we consider the mid-sagittal AP diameter, which is normally 13 to 16 mm. But if it is less than 10, then we call it spinal stenosis. There are other parameters also like lateral recess diameter, which is normally 7 to 11, intervertebral foramen diameter, which is normally 8 to 10 mm. So there are various grading system like clinical grading, radiological grading system, but in radiological grading system, basically it is based on obliteration of CSF space in front of the chorda equina and separation degree of the chorda equina. Based on this is from grade 0 to grade 3. These grading system are qualitative, but there is one more quantitative grading system as well, which is published in Asian Spine Journal in 2015 by Parisha. But this is a combination of this clinical grading, MRI grading, self-paced walking test, and stenosis ratio. So this is very complicated and it is very difficult to use in daily clinical practice. So what the literature said regarding this all grading system, there are two schools of thoughts in literature. One group, they found that there is between the MRI grading and patient disability and neurological impairment. At the same time, in other group of people, they found that there is poor correlation of patient clinical symptom and radiological severity. In our day-to-day clinical practice also, we get same result, because sometimes the patient is having severe symptom, but the MRI finding is not that much severe, and vice versa. So there are studies done in diagnosed case of lumbar spinal stenosis, which are followed up for more than 49 months without surgical intervention, and they found that the neurogenic claudication, which is main clinical feature of the stenosis, that remains in all patients, but that were in mild form. The another main feature is the pain, which remains same in 70% of the patient, and in 15% that the symptom improved, and in 15% that the pain is worsened. So that means in most of the patient, the symptoms either improve or remains unchanged. Even if we do a conservative, we don't do anything, either conservative or surgical treatment. Basically, physical therapy and drugs and epidural steroid injection. But epidural steroid injection are the technique are the transforaminal, and caudal. But we orthopedic surgeon and spine surgeon usually perform the transforaminal epidural steroid injection. But what the literature said, in literature, the role of epidural corticosteroid injection for central canal stenosis is not that much. But if the patient is having radiculopathy, there is some role of epidural corticosteroid injection. But that benefit also will remain for short time, and as the time passes, the benefit of steroid injection will start falling. Even there are no moderate or high grade of evidence for non-operative treatment. So and the systemic review article also, they conclude that there is insufficient evidence to recommend any specific type of the non-surgical treatment. So the symptomatic relief in a stenosis patient is by default. So what are the indications for surgery? Inadequate, though there are no high level of evidence, but still we give most of the patient, we start with the conservative treatment. And if there is inadequate response to conservative treatment, then the patient may need surgical management. Another is functionally disabled patient, progressively neurological deficit, and cauda equina syndrome. In case of cauda equina syndrome, there is no role of conservative treatment, so we'll straight away go to the surgical management. Though the patient requires surgery, but we need to identify the predictor for the surgical outcome. There are positive and negative predictors. If the patient is young, male patient, better walking ability, and if the stenosis is severe, in this group of the patient, the surgical outcome will be better. On the other hand, if the patient is having the neuropsychological problem like depression, or if any morbidity which influences walking capacity, or if severe deformity. So in this group of the patient, the outcome may not be as expected. So these predictors are very important to counsel the patient for their surgical outcome. So what are the approaches? In any spine surgery, the approach should be either posterior, lateral, or anterior. But anterior approach, there are a lot of comorbidity because of the mobilization of the ball and vessels. So nowadays, this anterior approach is not preferred. So most commonly nowadays, posterior and lateral approach are performed. The advantage of posterior approach is direct neural decompression, because in stenosis, the compression is mainly from the posteriorly, so we can decompress directly. And the other advantage is we can instrument anterior and posteriorly through the same incision. The advantage of lateral approach is minimal soft tissue disruption, and we don't need any excess surgeon like general surgeon or vascular surgeon like which needs in anterior approach. And the other advantage of this lateral approach is this is the preferred option for the treatment of adjacent segment degeneration after posterior spinal fusion. But the pitfall or shortfall of this lateral approach is this is not preferred for L5-S1 level. And if there is severe deformity, even L4, L5, this lateral approach is not preferred. So in surgical option, the approach will be the posterior and lateral. There is long list of surgical options from the posterior approach, started from the classic laminectomy to the TLIF surgery, and both the surgery we can perform by the open technique and minimal invasive technique. This is a traditional laminectomy which is performing since more than 100 years, but still we are doing this surgery. And this is after keeping the posterior midline incision, we split the muscle both sides, and we split up to the facet prominence, but we preserve the facet capsule, and also we expose up to the lateral border of the pars. Then once the adequate exposure, then we remove the spinous process and supraspinatus and interspinous ligament. Then we thin out the lamina on both sides, and then we remove the lamina. That's how we do the traditional laminectomy. And we must preserve this lateral 7 to 8 centimeter of 8 mm of pars to prevent the iatrogenic fracture. And the another surgery is laminoforaminotomy. In this, this is here spinous process and the ligament we preserve here. So basically, after the exposure, we do the laminotomy and remove the partial facet, and then also the ventral aspect of the spinous process we remove. Then ligamentum flavum, and then decompress the area. So if needed, we do the same process on the contralateral side also. This is a laminoforaminotomy bilateral technique, and the same thing we can do by the unilateral technique also. In unilateral technique, we expose only one side, and from that side only we will be able to decompress to the contralateral side also. But the disadvantage of this unilateral technique is we need a very precious lighting system and adequate good instrument. Otherwise, still there is chance of the incidental pterygotomy and nerve injury with this laminoforaminotomy unilateral technique. So, so for the beginners and where the facility is limited, it is always preferred this traditional laminectomy and laminoforaminotomy bilateral technique. So this is a 51 years old male patient with a lumbar stenosis L2, 3, 3, 4, and 4, 5, and there is a slight loss of lumbar lordosis, but dynamic film shows there is no instability. So in this case, we did this traditional laminectomy. Since we did a multi-level decompression and partial facet, so the damage of the multiple facet partially. So we did an instrumentation and lateral fusion. So what the literature says regarding this surgical management and conservative management, but in both the group, conservative group and surgical group, in the first few years in both the group, the clinical symptom improved, but more benefits in surgical group. But after a few years, 4 or 5 years, then the advantage of surgery starts falling, and long-term results are in both conservative and surgical group. It's equally. So the same this posterior decompression we can perform with minimal invasive technique, and the advantage of this technique is minimal soft tissue handling, and so that the less post-op pain and early mobilization of the patient. And the indication for the minimal invasive is single level, and either the stenosis is central or lateral recess. But the shortfall of this minimal invasive technique is this is difficult to treat the foraminal stenosis and inappropriate for very morbidly obese patient. And so whatever the surgery, either open technique or minimal invasive technique, two things are very important. First is the positioning of the patient, and second thing is imaging. After positioning the patient, the image, we need a true AP and true lateral view for spine surgery. In true AP view, the spinous process must lie in the center of the interpedicular space. And in true lateral view, the pedicles should overlie one another and end plates should be linear, not elliptical. So once we confirm the true AP and true lateral view, then we pass a QR, and that we in AP view that on the medial border of the facet, and in lateral view at the level of the disc, So once we fix the QR, we pass a serial dilator and finally fix with a tubular retractor and check the final image for to locate the area, to locate the level. So then next is we do the same procedure as in open technique. So once we did on one side, if needed, we can also perform on the contralateral side also just by angulating the tubular retractor. And on the contralateral side, we'll be able to remove only this hypertrophic ligament flavum and lateral recess area. We'll not be able to remove the lamina and in the foraminal area with this on the contralateral side. So whatever the surgery, even minimal invasive or open technique, but in both the group, the outcomes were favorable in both the groups at 1 year follow-up. So it doesn't matter whether the minimal invasive surgery or traditional laminectomy, the results were favorable in both the groups. So another is the lumbar interbody fusion. There are a lot. This is either posterior, transforaminal, or lateral, or oblique, or X-leaf. So whatever the interbody fusion, but the goal is same, just to increase the surface area, restore the disc height, and so that the foraminal height will maintain, and also to correct the deformity. So in posterior lumbar, in lumbar posteriorly we can do by the posterior P-leaf or transforaminal T-leaf, but the T-leaf is advantageous because this portal transforaminal window is more laterally located, so that the less dura and knob retractor and less chances of the neural injury happen in case of T-leaf. But whether in case of P-leaf, it's more of a centrally located and more retraction in the dura and knobs, so that more chances of the knob injury. So, so nowadays this T-leaf is preferred rather than P-leaf. So once the exposure, in case of T-leaf, we remove the inferior facet of the cephalate vertebra, start from the just below the pars, and then superior facet of the caudate inferior vertebra. We cut the superiorly horizontal cut, and inferiorly there is a lateral cut. Then also we remove the lamina of the inferior vertebra. So once we remove these bony parts, then we can see the this exiting knob roots and traversing knob root. So in between we can see the disc space clearly. So we do the annulotomy and we remove the disc and we prepare the end plate and measure with the. Once we prepare the end plate, then we put a cage. That's how we do the T-leaf surgery. So this 59 years old patient with the L4L5 spondylolysis with a spondylolisthesis, and there's a L4L5 stenosis more on the left side. And in this case, we did a T-leaf surgery and patient feel better. So the same T-leaf surgery we can also do with a minimal invasive technique. In this surgery also, the main thing is positioning of the patient, and the imaging is very important. After this positioning and imaging, then we draw one line feeling the spinous process, and the other two lines on the side. This is 3.5 to 4 centimeter away from the midline. So once drawing this line, then we pass a QR to mark the label, and in AP view, just we put up a QR just medial to the facet. In the lateral view, this the imaginary line should pass through the disc space. So this is that's how we locate the area. And once we locate the area, we insert the pedicle screw to the percutaneous technique, and we pass a serial dilator through the K wire, and finally we put a tubular retractor, and then and rest of the procedure will be the same as in open technique. So next is interspinous spacer. The only indication of the interspinous spacer device is neurogenic intermittent claudication, which exacerbates in extension and relief in flexion with failed conservative treatment and without spondylolisthesis. So what will happen in degenerative condition, once the disc height is decreased, loss of disc height, and that leads to the annular bulging and enfolding of the ligamentum flavum, and that leads to the stenosis of the canal. So how does this IPT device works? This IPT device that produces the focal flexion of the spinal segment, and that leads to the ligamentum flavum tight and increase the spinal canal diameter. So literature mentioned that the IPT device increased the neural foramen area by 26%, and in spinal area it's by 18%. But what the systemic review articles and meta-analysis articles says, this current evidence indicate that no superiority of this IPT device over this traditional bony decompression, because though there are initially there are surgical advantage in IPT device, but this IPT device has high resurgery rate, revision surgery rate. 15 to 25% of the IPT patient needs revision surgery. So this device is also not superior to the traditional bony decompression. So another is a posterior facet fusion. The only indication for the posterior facet fusion is just to augment the interbody fusion. There are two techniques. One is Boucher ipsilateral and another is Mageral translaminar. This Mageral translaminar has can cause laminar fracture, and more complications. So nowadays this Boucher ipsilateral transfacet technique is preferred. And the interportal for this Boucher ipsilateral technique is we draw one line from the lower border of the vertebra, and the other line just medial to the pedicle. So where it crosses, that is the interportal for the guide wire, and the guide wire should pass 15 degree infero and laterally, 15 and 30 degree caudally. So in lateral view, that guide wire passed through the pedicle and up to the pedicle vertebra junction. So that's how we insert the this guide wire and screw for the facet fusion. So finally, this lateral approach, lateral lumbar interbody fusion only for X-slip. So again, in this case also there is a positioning is important. We bend the bed at the level of the greater trochanter, but too much bending sometime will be disaster, because it can cause the lumbar plexus injury and plexus injury. So there is again once we position the patient, there is single incision or dual incision technique, but whatever the technique, that is single or double incision technique, but main thing is the landmark will be the psoas muscle. This either trans psoas, this is lateral lumbar interbody fusion and X-slip. This is trans psoas, and olive, which is just p-psoas anterior to the psoas. So once we locate the psoas, we pass the tubular retractor, serial tubular retractor. Just we split the psoas muscle if that is trans psoas, but nowadays we prefer this is p-psoas, that is olive, and we pass the serial dilator. This dilator as neuromonitoring system also. And once we pass the dilator, then we reach the disc space, and we can remove the disc and prepare the end plate, and we can pass the this keys after preparation of the end plate. So the only complication in the lateral lumbar interbody fusion is a transient hip flexor weakness because of the lumbar plexus injury, and sometimes this abdominal visceral injury, which is not common, it's rare. So take home message is, though there is there are various grading system, but still clinical symptom and sign that should be deciding factor for the treatment modality for the stenosis patient. Though there are no high-level evidence, high-level clinical evidence, but still conservative treatment is always the first choice. And traditional laminectomy is still a good option, especially for beginners and where the average facility setup is available. So whatever the types of surgery, either open or a minimal invasive technique, but the goal of surgery should be decompression and spinal stabilization. And minimal invasive surgery are becoming popular because of perception of better outcome and quicker recovery from the surgery. But what we found in literature is that the outcome in both open technique and minimal invasive surgery are comparable. But because of the less soft tissue handling in minimal invasive technique, the patient feel quicker recovery because less soft tissue handling, less pain, and early hospital discharge. That's why patient feel quicker recovery. Thank you. I hope I finished within time. Any question in chat box?
I think there isn't anything, Bishnu.
Now, if there is no any question, now I request our NOA scientific chair, Dr. Sailaj, for a vote of thanks.
Thank you,
Over to
Bishnu,
Dr.
and thank you, everyone. Thank you, Bishnu, and thank you, everyone, to have participated on this rainy Sunday morning. And we hope to meet you all again. I would like to let you know that the next meeting is on the 31st of July. It's going to be on hand. So it's a subspecialty meeting from NOA. And following that, the normal bi-monthly meeting will be on the 28th of August. It will be by Grandie International Hospital. That's all I have to say, and hopefully everyone has a very nice Saturday. Thank you very much for participating. Have a good day. Thank you, Bishnu, and thank you, Army Hospital, for taking all the pain and trouble. Thank you so much.
Lunch box serve गर्ने हैन शैलाज
घरमा इन्टरनेटबाट पठाइदे होला गर्न पाए त राम्रै हुन्थ्यो हजुर हैन
Anyway, it was very good, interesting. Thank you.
Thank you very much.
Sir. Thank you, sir.
Thank you, everyone, Hazur.
Okay, thank you, everyone.